This is an AI-generated podcast summary based on a chapter from the book Gastroenterology Clinical Focus by Dr. Emad Qayed.
Welcome back to the Deep Dive. Today we are taking a deep breath and plunging straight into one of the most stressful and clinically complex emergencies in medicine, gastrointestinal bleeding.
So our mission today is really to distill the core knowledge from the sources, those high-stakes decisions.
We'll be navigating from common peptic ulcer disease, PUD, to the complexities of variceal hemorrhage, and even trying to hunt down those really elusive sources of obscure bleeding deep in the small bowel.
And the sources consistently point to three sort of non-negotiable skills here.
Yeah.
Aggressive but careful resuscitation, figuring out the optimal timing for endoscopy, usually within 24 hours for the high-risk folks. And then, of course, delivering effective endoscopic techniques when you get there.
All right, let's unpack this huge topic, starting with the most frequent cause we run into, peptic ulcer disease bleeding.
So, patient comes in. First thing is assessment, right? Trying to gauge the magnitude and, if possible, the location of the bleed. Clinical clues are vital.
Like melena, the black tarry stool.
Exactly. That usually means slower bleeding, maybe 50 to 100 milliliters lost. Gives the blood time to get digested, so it often points to an upper GI source. Though sometimes it can be small bowel or even right-sided colon.
Okay, contrast that with hematochezia, bright red blood, but coming from an upper source. That sounds terrifying.
It is. For blood from the stomach or duodenum to come out bright red, it means the bleeding is massive and fast. We're talking probably over a liter of blood loss, moving too quickly through the gut to change color.
And this brings up a really important diagnostic pitfall, doesn't it? The nasogastric tube aspirate.
Oh, absolutely. We often rely on it, stick a tube down, see if there's blood, but the sources are clear. A negative NG aspirate does not rule out a high-risk upper GI lesion.
How often does it miss?
Up to 15% of the time. You could have a nasty posterior duodenal ulcer bleeding away, and the NG tube comes back clear. So you can't hang your hat on it entirely.
15%.
Yeah.
That's high enough to make you nervous.
Yeah.
So beyond the NG tube, what factors really tell us this patient is in trouble? The high-risk predictors.
Yeah, several things flag a poor outcome. Age over 60 is one. Significant comorbid diseases, especially heart disease. Hemodynamic instability, so hypotension, tachycardia,
Right.
and needing a lot of blood. Specifically, if they require 6 or more units of packed red blood cells, that's a major red flag for a worse prognosis. We have to jump on those things immediately, starting with resuscitation.
Which leads us to, I think, one of the biggest shifts in managing GI bleeds recently.
Yeah.
The transfusion strategy. Restrictive versus liberal. Feels counterintuitive, doesn't it? Giving less blood is better.
It absolutely does feel counterintuitive, but the landmark randomized controlled trial really turned things on their head. The old way, the liberal strategy, aimed to keep hemoglobin above 9 grams per deciliter. The restrictive strategy set the threshold much lower, at 7 grams per deciliter. You only transfuse if the hemoglobin drops below 7, and then you aim to keep it in that 7 to 9 range.
And the results were pretty dramatic.
Undeniably. The restrictive strategy was significantly better across the board. It wasn't just a minor difference.
I bet better.
Well, all-cause death within 45 days dropped from 9% in the liberal group down to 5% in the restrictive group.
Wow.
Further bleeding dropped from 16% down to 10%. Overall adverse events went from 48% down to 40%. It was a clear win for the restrictive approach.
So why? Why does giving less blood lead to better outcomes? It seems backwards.
The main theory, and this is particularly relevant for patients with liver disease, revolves around portal pressure. The idea is that over-transfusing, giving too much volume with the liberal strategy can actually increase portal venous pressure. And if you raise that pressure, you might just pop a fragile clot right off the bleeding vessel. The study even showed that cirrhotic patients, Child-Pugh A or B, had much better mortality with the restrictive strategy, 4% versus 12%. It really supports this idea that avoiding volume overload is critical.
But we need to be careful about who this applies to, right? There were important exclusions in that trial.
Absolutely crucial point. The study excluded patients with active ischemic heart disease, things like acute coronary syndrome, recent stroke, or TIA. So we can't confidently apply this restrictive strategy to those specific high-risk cardiac groups.
Got it.
And of course, if someone is in profound shock, exsanguinating right in front of you, you start transfusing immediately, regardless of the starting hemoglobin.
Okay, makes sense. What about coagulopathy? Fixing the clotting factors versus getting to the scope.
The rule here is pretty clear. Correct the coagulopathy, yes, but don't let it significantly delay the endoscopy. Interestingly, studies suggest even mild or moderate INR elevations don't dramatically hike the rebleeding risk after you've done endoscopic therapy.
And how we correct it has changed too. PCC over FFP.
Yes, prothrombin complex concentrate, TCC, is now generally preferred over fresh frozen plasma, FFP.
Why is that? Just practically speaking.
PCC works faster and more reliably to bring the INR down. It's a concentrated dose of specific clotting factors in a really small volume. FFP, on the other hand, takes time to thaw, and you have to give a much larger volume.
Right, which circles back to avoiding that volume overload we just talked about.
Exactly. The speed and the low volume make PCC the better choice in an acute bleed.
Okay. And what about platelets? If someone's on aspirin or Plavix, but their platelet count is normal, do we give platelets?
This is another area where practice has shifted. For those patients' normal platelet count, but taking antiplatelet drugs, platelet transfusions are actually not recommended.
Oh,
Not recommended.
yes.
There was a study that actually linked giving platelets in this specific situation not just to zero benefit in stopping rebleeding, but potentially to increased mortality compared to not giving them.
Wow, so the focus has to be on physically stopping the bleed with the scope.
Precisely. Mechanical or thermal hemostasis is the goal, not just throwing factors or platelets at the problem if the count is already normal. #ProgTag 1.2, pre- and post-endoscopy medical therapy.
Okay, patients stabilized, resuscitation's underway, we're thinking about the scope. Are there things we can do medically before the endoscopy to improve our chances?
Yes, definitely. One key thing is using IV erythromycin. It's a prokinetic agent.
Okay.
We give it about 30 to 90 minutes before the scope. Standard dose is usually 3 mg/kg or just a flat 250 milligram IV.
And what's it doing?
It's purely mechanical, really. It speeds up gastric emptying, helps clear out any remaining blood or clot from the stomach. This makes a huge difference in visualization.
Better view, easier to find the lesion.
Exactly. Less blood means you're less likely to miss something important.
And what about giving PPIs before the scope? The sources say they don't actually change mortality or rebleeding rates at that stage, so why bother?
It's more of an operational benefit. Giving a PPI beforehand increases the chance that when you scope the patient, you'll find an ulcer that's not actively bleeding. Maybe it has a clean base instead of a visible vessel.
Ah, so it might downgrade the lesion's appearance.
Sort of. It makes it less likely you'll need to do aggressive endoscopic therapy right then and there. It can potentially streamline the procedure and maybe even reduce complications from the intervention itself.
Okay, now the timing of the EGD itself. Consensus seems to be within 24 hours for high-risk patients. But wasn't there a study looking at urgent endoscopy, like within 6 hours, versus just early endoscopy, say 6 to 24 hours? Did rushing help?
Yeah, there was. And interestingly, that trial found no significant difference in 30-day mortality or in rates of persistent or recurrent bleeding between the urgent under 6 hours group and the early 6-24 hours group.
So rushing an unstable patient to the scope doesn't actually improve survival.
It seems not. The key takeaway is that stabilizing the patient first is more important than just speed for speed's sake. Getting them stable and then scoping within that 24-hour window seems to be the optimal approach for high-risk patients.
Stability first, procedure within 24 hours.
Got it.
Now, let's say we've done the scope, found a high-risk lesion, and treated it. What's the critical medical therapy after the procedure?
This is where high-dose IV PPIs are absolutely essential. For those high-risk lesions, active bleeding, visible vessel that you treated, you need 72 hours of high-dose IV PPI.
What's the standard regimen?
Typically an 80 milligram bolus right after the procedure, followed by a continuous drip of 8 milligrams per hour for 3 days. This has been shown time and again to dramatically decrease rebleeding rates and even improve mortality.
And is IV the only way? What about high-dose oral?
Actually, newer data suggests that high-dose oral PPIs, given frequently enough, can be comparably effective to the continuous IV infusion for maintaining that high level of acid suppression needed for clot stability.
Okay, good to know. Now let's tackle the aspirin dilemma. This feels like walking a tightrope, especially for patients with cardiovascular disease who need their aspirin.
It's one of the toughest calls we make, honestly. You're balancing the risk of the ulcer rebleeding against the risk of the patient having a heart attack or stroke if you stop their aspirin.
What do the big trials show on this? Restarting aspirin versus keeping it held?
The results were stark. Restarting low-dose aspirin immediately after you've achieved endoscopic hemostasis significantly lowered 30-day mortality. It dropped from 9% in the group where aspirin was held down to just 1.3% in the group where it was restarted.
That's a massive mortality benefit, saving almost 8 lives per 100 patients.
Huge, primarily by preventing cardiovascular events.
Well, there's always a but, isn't there? What was the cost?
The cost was a significantly higher rate of rebleeding. It more than doubled in the aspirin group, jumping from about 5.4% up to 10.3%.
So you save them from a heart attack, but you double their chance of coming back with another bleed. That's a difficult conversation.
It really is. It requires a careful, documented discussion, ideally involving cardiology input. You're making a conscious choice, supported by this data, to accept a higher GI bleeding risk to mitigate a potentially fatal cardiovascular risk. Hashtag 1.3 endoscopic treatment and salvage. All right, so when we're actually doing the endoscopy, our treatment plan is largely dictated by the Forrest classification. It categorizes the ulcer based on its bleeding stigmata.
Right. Helps decide who needs treatment and how aggressive to be. Let's break it down. What about active bleeding? Forrest, yeah, and Nib.
Forrest is active spurting, like a little arterial pump. Eve is active oozing. For both of these, you need dual endoscopic therapy, no question.
Dual therapy meaning?
Meaning you combine epinephrine injection with a second, more definitive method. Usually that's thermal therapy, like with a bipolar probe, or mechanical therapy with endoclips. And then, of course, they get the 72 hours of high-dose IV PPI afterward.
Okay. What about Forrest EA, the non-bleeding visible vessel?
Same approach. Dual endoscopic therapy plus the IV PPI. Even though it's not actively bleeding at that moment, a visible vessel has a very high risk of rebleeding, so we treat it just as aggressively.
Now, the tricky one. Forrest IB, the adherent clot. What's the play there?
The standard approach is to be aggressive. You should try very carefully to irrigate and suction that clot off. Often, there's a high-risk lesion like a visible vessel hiding underneath it.
And if you get the clot off?
Then you treat whatever you find underneath. If it's a visible vessel, you treat it as an II with dual therapy. If you can't safely remove the clot, the patient still needs intensive PPI therapy after the scope, and some might even consider empiric injection therapy near the clot.
Okay. And which lesions can we safely leave alone endoscopically?
That would be the Forrest Ike, which is just a flat pigmented spot like old blood in the ulcer base, and Forrest III, a completely clean-based ulcer. These have a very low risk of rebleeding, so no endoscopic therapy is needed. You just switch them to standard oral PPI therapy.
Let's talk about the tools. Epinephrine injection. How does squirting epi actually stop bleeding?
It works in two main ways. First, the volume you inject creates direct mechanical tamponade on the bleeding vessel. Second, epinephrine is a potent vasoconstrictor, so it clamps down the vessel locally.
But it's temporary, right?
Absolutely. It's mostly a bridge. It buys you maybe 3 to 5 minutes of relative calm to apply your definitive therapy, like the clips or the thermal probe. It's rarely sufficient on its own for high-risk lesions.
Okay. And thermal therapy, you mentioned bipolar probes.
Yeah.
How are they different from monopolar? Why does it matter?
This is an important safety distinction. The goal of thermal therapy is coaptive coagulation. You press the probe onto the vessel and use heat to basically fuse the walls shut. With bipolar probes, the electrical current flows just between the two electrodes right at the tip.
So the current stays very localized.
Exactly. It's contained, doesn't travel through the patient's body. That makes it generally safer with less risk of deep tissue injury.
And monopolar?
Monopolar is different. It uses a single active electrode at the tip, and the current has to pass through the patient's body to a grounding pad placed somewhere else on their skin. While it works, there's a theoretical slightly higher risk of unintended burns or injury away from the target site. For most standard ulcer bleeding, bipolar probes are the go-to.
Got it. We also have newer clipping technology now, like the over-the-scope clips, OTSC. How are they different?
OTSCs are much bigger and stronger than the standard through-the-scope clips. They look kind of like a bear trap on the end of the scope. They're designed to grab a much larger amount of tissue, including the deeper layers.
So for tougher situations.
Exactly.
Yeah.
They're often used for severe rebleeding when standard clips fail, sometimes for closing perforations or for really difficult to treat lesions like Gillifoys.
And then there's hemostatic powder, like hemospray. Sounds pretty cutting edge.
It is. It's basically a powder you spray onto the bleeding site. It works by absorbing water, concentrating clotting factors, and creating a mechanical barrier. It also helps activate the clotting cascade.
And it works well initially.
Phenomenally well. The immediate success rate in stopping bleeding is incredibly high, like over 95%. But its durability is the issue. It's often used as a temporary measure, maybe for diffuse bleeding, like from a tumor, or when other methods have failed. The rebleeding rate at 30 days can be significant, maybe around a third of patients. So it buys you time, but might not be the final fix.
A bridge to something else, potentially.
Yeah.
So what happens when endoscopy just fails? For that small percentage where the bleeding won't stop?
Yeah, thankfully it's less than 4% of cases, but when it happens, you need salvage therapy. The main options are angiography with embolization, where interventional radiology goes in and plugs the bleeding artery, often guided by a clip we place endoscopically, or as a last resort, surgery to oversew the ulcer.
Okay, let's move beyond standard ulcers. What other things in the upper GI tract can cause significant bleeding? #tag 2.1 traumatic and pressure-related lesions.
Well, one common one, especially after forceful vomiting, is a Mallory-Weiss tear, or MWT.
Right, those longitudinal tears near the stomach-esophagus junction, often related to alcohol use.
Very often, yes. The sudden increase in pressure causes a mucosal tear. The good news is most of these, probably 80–90%, stop bleeding on their own.
But if they're bleeding actively when you scope them?
Then you can treat them endoscopically. Options include enderclips, thermal coagulation, or even band ligation, similar to how we treat varices sometimes.
Now, related but much, much more severe is Borhave syndrome. This isn't just a tear, is it?
No, Borhave is a complete full-thickness rupture of the esophagus, transmural. Usually from incredibly forceful vomiting. It's a true surgical emergency.
And the classic signs?
Vomiting, followed by severe tearing chest pain, and often subcutaneous emphysema. You can feel crackling under the skin in the neck as air escapes.
What's the absolute #1 rule for endoscopy if you suspect Borhave?
Don't do it. Endoscopy is generally contraindicated. Putting air and the scope itself into the esophagus can worsen the perforation, push gastric contents into the chest. It's dangerous. Diagnosis is usually made with imaging, like a contrast swallow study or a CT scan. Management is almost always surgical repair.
Okay, crucial warning there. What about Cameron lesions? These are related to hiatal hernias, right?
Exactly. They are linear erosions or actual small ulcers found right at the spot where a large hiatal hernia gets pinched by the diaphragm as it slides up into the chest.
And how do they usually present?
Less often with massive acute bleeding, though it can happen. More commonly, they cause chronic, slow, occult blood loss that leads to significant iron deficiency anemia. Management is usually high-dose PPIs to heal the erosions, lots of iron replacement, and endoscopic therapy only if you catch them actively bleeding. #tag 2.2 vascular anomalies and malignant bleeding.
All right, shifting gears to vascular issues. Dulossois lesion. Sounds dramatic.
It can be. It's essentially a large, abnormal, tortuous artery running just beneath the mucosa. For some reason, it erodes through the surface without forming a surrounding ulcer. It just pokes through.
And location?
Often found near the GE junction, maybe on the lesser curve of the stomach. When they bleed, they can bleed massively and suddenly, often without warning.
Treatment.
Yeah.
Needs to be definitive, I imagine.
Absolutely. Thermal coagulation, placing endoclips, or even band ligation are the mainstays. The key point here, different from ulcers, is that just injecting epinephrine alone is not enough. The artery is too big, the epi effect will wear off too quickly. You need a definitive mechanical or thermal fix.
Okay. Next up, gastric antral vascular ectasia, or GAVE, known more famously as
watermelon stomach.
Yeah, the endoscopic appearance is pretty classic. You see these linear rows of red dilated blood vessels, these ectasias running along the folds of the gastric antrum, looking like the stripes on a watermelon. Sometimes it's more diffuse and nodular too.
And it causes significant bleeding. Oh yes. Often chronic recurrent bleeding, leading to profound iron deficiency anemia and transfusion dependence.
Now, GAVE often gets confused with portal hypertensive gastropathy, PHG, but there's a critical difference in the underlying cause, isn't there?
This is probably the single most important thing to remember about GAVE. Its bleeding is completely unrelated to portal hypertension. These are primary vascular abnormalities in the stomach lining.
So treatments aimed at lowering portal pressure won't work?
Correct. Things like TPS or beta blockers, which we use for varices or PHG, are totally ineffective for GAVE bleeding.
So how do you treat GAVE effectively?
The treatment has to be local, targeting the ectasias themselves. The standard is argon plasma coagulation, or APC. It uses argon gas to deliver electrical energy without direct contact, basically cauterizing the surface vessels. It often takes multiple sessions.
And interestingly, it can resolve completely if the patient gets a liver transplant.
Yes, if the underlying liver disease that's often associated with GAVI is cured by transplant, the GAVI itself tends to resolve. It's quite fascinating.
Lastly, in this section, what about bleeding from malignant tumors? Is that harder to control?
Much harder, unfortunately. Tumors bleed because they develop abnormal, fragile new blood vessels neovascularization, and also because the tumor itself can directly invade into larger, normal vessels.
And standard endoscopic trachs don't work as well.
Generally, no. Things like coagulation, injection, clips, even the powder tend to be less effective, and the bleeding often recurs quickly. Rebleeding rates are very high. Often you're looking at palliative measures, maybe radiation therapy, rather than definitive endoscopic control.
Okay, now we move into arguably the highest risk scenario for upper GI bleeding. Variceal hemorrhage in a patient with cirrhosis, hashtag 3.1, acute esophageal variceal bleeding.
Yeah, this is often catastrophic. Acute variceal bleeding is responsible for about a third of all deaths related to cirrhosis. It's incredibly dangerous.
And while some stop bleeding on their own.
About half might stop spontaneously, but the risk of rebleeding is huge, around 30% overall, and critically, about 40% of those rebleeds happen within the first 5 days. Mortality rates remain depressingly high.
So the initial management has to be incredibly fast and aggressive.
Absolutely. These patients go straight to the ICU, no question. If they have massive hematemesis or any signs of hepatic encephalopathy, they need to be intubated immediately to protect their airway.
Transfusion strategy. Still restrictive.
Yes, the goal is still generally restrictive, aiming for a hemoglobin between 7 and 9 GDL. Overtransfusion is particularly dangerous here because it can directly increase portal pressure and worsen the bleeding.
Okay. And medically, what are the pillars of treatment right away?
First is vasoactive therapy. We use IV octreotide, which is a somatostatin analog.
How does that work?
It causes vasoconstriction specifically in the splanchnic circulation, the blood vessels supplying the gut. This reduces blood flow into the portal system, which lowers the pressure inside the varices themselves. Standard dose is a 50 microgram bolus, then a 50 microgram per hour drip, usually continued for up to 5 days.
And the other critical medical intervention, the one that really drives down mortality.
Antibiotics. This is absolutely non-negotiable. Every single cirrhotic patient admitted with any upper GI bleed, whether it's variceal or not, must receive prophylactic antibiotics.
Why is that so critical?
Cirrhotic patients are incredibly susceptible to bacterial infections, especially spontaneous bacterial peritonitis, SBP. An active GI bleed seems to increase this risk further. Giving antibiotics, usually an IV cephalosporin like ceftriaxone for about 7 days, significantly decreases the rate of infection, which in turn reduces rebleeding rates and has a major impact on improving overall survival. It's standard of care.
Okay, so antibiotics are a must. What about the endoscopy itself? Timing and treatment.
EGD should be performed within 12 hours of presentation. Once you identify bleeding esophageal varices, the treatment of choice is endoscopic variceal ligation, or EVL.
Banding them, basically.
Exactly. You place small elastic bands around the varices, which cuts off their blood supply. They thrombose, necrose, and eventually slough off, hopefully obliterating the varix. You typically place bands moving down the esophagus in a spiral pattern.
What if banding fails? Or the bleeding is just too torrential to even see?
Then you have to move to mechanical tamponade, usually with a Sangstein and Blakemore or a Minnesota tube. These are balloon tamponade devices.
These sound intense and risky.
They are. They're temporary measures used to control bleeding to bridge the patient to a more definitive therapy, like TPS, or maybe just stabilize them for transfer. They absolutely require the patient to be intubated first.
How do they work?
You insert the tube down into the stomach. Confirming placement with X-ray or scope is crucial. Then you inflate the gastric balloon first, usually with about 300 to 400 milliliters of air, and pull gently to seat it against the GE junction. This alone might stop the bleeding if it's coming from gastric varices near the junction.
And if bleeding continues from esophageal varices?
Then you inflate the esophageal balloon. This applies direct pressure onto the esophageal varices, but, and this is critical, the esophageal balloon pressure needs to be monitored, usually kept around 35 millimilli G, and it absolutely cannot stay inflated for more than 12 hours straight.
Why the time limit?
The risk of pressure necrosis. Leaving it inflated too long can kill the esophageal tissue, leading to ulceration, perforation, potentially fatal complications. It's a very temporary, very high-risk bridge.
Are there alternatives to balloons now? Like stents?
Yes. Temporary, fully covered, self-expanding metal stents are being used more. Some studies suggest they might achieve better bleeding control with fewer complications compared to balloon tamponade. However, stent migration is a big problem. They can move out of place quite frequently, sometimes over 50% of the time. So, still considered temporary. Hashtag 3.2 advanced variceal interventions and gastric varices.
If banding fails, or maybe even before it fails in very high-risk patients, we have TIPS, the transjugular intrahepatic portosystemic shunt, and the data on doing TIPS early, preemptively, seems really impressive.
It's been a genuine game changer, particularly for the highest risk patients. This is called preemptive TIPS, or P-TIPS.
Who qualifies for P-TIPS?
It's indicated for patients with Child-Pugh Class C cirrhosis or Child-Pugh Class B who has active bleeding seen during their initial endoscopy. And the key is timing the TPS procedure should be done within 72 hours, ideally within 24 hours of that index EGD.
And the outcomes. Why is it considered such a big deal?
The outcomes are striking. In the landmark trial for these high-risk patients, P2PS improved one-year survival dramatically from 61% in the group getting standard therapy, banding, meds, up to 86% in the P2PS group.
Wow, that's huge.
And freedom from rebleeding at 1 year. It jumped from 50% up to 97%. It fundamentally changes the prognosis for these very sick patients. It reframes TPS not just as salvage, but as early, definitive therapy for the right patient.
Okay, that's esophageal varices. What about gastric varices? They're managed differently, aren't they, based on location?
Yes, the classification matters. GEV1 are varices that are basically extensions of esophageal varices down into the cardia. They can often be treated like esophageal varices, usually with EVL banding.
But the other types, GEV2, IGV1, IGV2?
Right. GEV2 involve the fundus, but extend from esophageal varices. IGV1 are isolated varices just in the fundus. IGV2 are isolated varices elsewhere in the stomach. These fundal varices, GEV2 and IGV1, are generally larger, thicker walled, and bleed more severely. Banding is often ineffective or risky for these.
So what's the preferred treatment for those fundal gastric varices?
TPS is generally considered the treatment of choice for controlling bleeding from GEV2 and IGV1 gastric varices. It addresses the underlying high pressure effectively.
What if KIPSIS isn't an option or fails? Can they be treated endoscopically?
Yes, the main endoscopic option is endoscopic variceal obturation, which means injecting them with cyanoacrylate glue, basically medical-grade superglue.
Glue. That sounds also risky.
It has risks. The glue isn't actually FDA approved for this indication in the U.S., though it's used commonly off-label. The biggest concern is glue migration. Bits of hardened glue can break off and travel through the bloodstream, causing potentially fatal embolisms in the lungs or brain. It requires expertise.
Are there non-endoscopic, non-TPS options?
Yes. Interventional radiology offers techniques like BRTO, balloon-occluded retrograde transvenous obliteration, or variations like BETO, balloon-occluded anterograde transvenous obliteration.
How do those work?
Essentially, the IR dock accesses the large shunt vessel that's often feeding the gastric varices, usually a gastrorenal shunt for BRTO. They inflate a balloon to block blood flow out of the varix and then inject a sclerosing agent directly into the varix to thrombose and obliterate it. It's very effective, especially for gastric varices when TPS isn't suitable. Hashtag 3.3 variceal prophylaxis and gastropathy.
Okay, let's shift from acute bleeding to prevention. Primary prophylaxis stopping the very first bleed. Who needs screening?
All patients with known decompensated cirrhosis need an EGD to screen for varices. For patients with compensated cirrhosis, though, we can sometimes avoid screening EGD using non-invasive tests.
How does that work?
If their liver stiffness measurement, or LSM, on something like FibroScan is less than 20 kPa and their platelet count is greater than 150,000, their risk of having clinically significant varices, medium or large ones, is very low, and you can likely defer the EGD.
But if they don't meet those criteria or they have decompensated cirrhosis, they get scoped. Who then needs treatment to prevent a first bleed?
You treat patients who are found to have medium or large varices on screening EGD. Also, patients considered to have clinically significant portal hypertension, or CSPH, typically defined by an HVPG measurement over 10 mmHg, or maybe an LSM over 25 kPa, even if they only have small varices, should be considered for prophylaxis.
And what's the preferred treatment for primary prophylaxis?
Non-selective beta blockers, or NSBBs, are the first choice. Drugs like carvedilol, propranolol, or nadolol. They work by reducing cardiac output and causing some splanchnic vasoconstriction, which together lower portal pressure. Carvedilol might be slightly preferred now due to some additional effects.
What if someone can't tolerate beta blockers, side effects, asthma, etc.
Then the alternative for primary prophylaxis is serial endoscopic variceal ligation, EVL. You basically band any existing varices until they're obliterated, doing sessions every 2 to 4 weeks until it's done.
Okay, that's primary prevention. What about secondary prophylaxis, preventing a rebleed in someone who's already had a variceal hemorrhage?
Secondary prophylaxis needs to be more intensive. The standard of care is combination therapy. That means using both an NSBB, propranolol, or notalol are usually used here, plus serial EVL sessions to obliterate any remaining varices.
So drugs and banding together.
Yes, combination therapy provides better protection against rebleeding than either modality alone. The only time you wouldn't necessarily do this combination is if the patient has already had a successful TIPS placed, as the TIPS itself provides the necessary pressure reduction.
Got it. Lastly, in this section, let's quickly revisit portal hypertensive gastropathy, PHG, and make sure we distinguish it clearly from GAVE, watermelon stomach.
Right. Key differences. PHG typically affects the proximal stomach more. The body and fundus show changes, often a mosaic or snakeskin pattern. GAVE is usually in the antrum. And critically, the severity of PHG does correlate directly with the level of portal hypertension.
Which means
Treatments that lower portal pressure, NSBBs or TIPS, are effective for managing bleeding from PHG, unlike GAVE where they don't work. So understanding the underlying cause dictates the right treatment.
All right, let's head downstream, past the ligament of Treitz into the territory of lower GI bleeding. #ShagTag 4.1 definition, etiology, and resuscitation.
So LGIB is basically bleeding originating anywhere from the jejunum down to the anus, practically speaking, anywhere distal to where a standard EGD can reach.
And the most common causes.
By far, the most common cause is diverticulosis, bleeding from those small outpouchings in the colon wall. Angiodysplasia, similar to what we see in the small bowel, is another major cause. The good news about diverticular bleeding is that it stops spontaneously in the vast majority of cases, maybe 90%.
Resuscitation principles are similar to UGI bleeding, right? Volume, restrictive transfusion.
Exactly the same principles apply. Stabilize the patient first. The big challenge, especially with brisk hematochezia, bright red blood per rectum, is being absolutely sure it's not actually a massive upper GI bleed that's just moving through really fast.
So when do you absolutely need to rule out an upper source first?
You have to strongly consider or perform an EGD first in any patient with severe hematochezia who is hemodynamically unstable, especially if they have risk factors like known cirrhosis, a history of peptic ulcer disease, or if their BUN to creatinine ratio is high, say over 30. That ratio suggests blood is being digested higher up. #Tag 4.2 colonoscopy and imaging timing.
Okay, assuming we've ruled out an upper source so the bleeding is less severe, what's the thinking on the timing of colonoscopy for LGA? Used to be a push for urgent scopes, wasn't there?
There was, yeah. Guidelines used to strongly recommend colonoscopy within 24 hours. However, more recent data, including multiple randomized trials and meta-analyses, has really challenged that.
What did they find?
They consistently found that doing an urgent colonoscopy within 24 hours does not seem to improve key clinical outcomes, things like rates of further bleeding, need for surgery, length of stay, or mortality, compared to doing an elective colonoscopy later, typically within 24 to 96 hours after the patient is stable and has had a good bowel prep.
Why wouldn't rushing help?
Probably because, as we said, most diverticular bleeds stop on their own. Rushing in with an urgent scope often means the bowel prep is poor, visualization is terrible, you might miss the source, and you can't effectively do therapy anyway. It seems better to stabilize the patient, give them a really good clean-out prep, and then do a high-quality elective colonoscopy within that 24-96-hour window.
Makes sense. If you do find a source during colonoscopy, like active diverticular bleeding or maybe post-polypectomy bleeding, what can you do?
Standard endoscopic tools work well here too. Endoclips are commonly used, especially for post-polypectomy bleeding or visible vessels in diverticula. Thermal therapy can also be used, sometimes injection therapy. Band ligation has even been described for diverticular bleeds.
What about meds? Should NSAIDs be stopped?
Yes, any non-aspirin NSAIDs should definitely be stopped if possible, as they can contribute to diverticular bleeding and ulceration. Aspirin is trickier, similar to the PUD situation. It's usually continued if the patient has a strong cardiovascular indication, accepting the slightly increased bleeding risk.
Okay. And if the patient is too unstable for a scope, or the scope fails to find or control the bleeding, what imaging comes next?
For hemodynamically unstable patients with ongoing severe LGAB, the next step after resuscitation is usually a CT angiogram, CTA.
Looking for active contrast leaking out.
Exactly. If the CTA shows active extravasation identifying the bleeding site, the patient can then proceed immediately to conventional angiography with the interventional radiology team for transarterial embolization plugging the vessel.
How sensitive are these scans? Is there a minimum bleeding rate needed?
Yes, and it's an important difference. Angiography, both CTA and conventional, generally needs a fairly brisk bleeding rate to detect the source, typically at least 0.5 to 1 milliliter per minute. Radionuclide scans, the tagged red blood cell scans, are much more sensitive. They can sometimes detect bleeding rates as low as a 0.1 milliliters per minute.
But the radionuclide scan isn't therapeutic, right? It just tells you roughly where it is.
Correct. It can help localize the bleeding to a region of the bowel if it's slow and intermittent, but CTA is generally preferred in the acute, unstable setting because it directly guides the potentially therapeutic angiography.
All right, we scope the top, scope the bottom, and the patient is still bleeding, or it keeps rebleeding. Now we enter the challenging realm of the small bowel and obscure GI bleeding. Hashtag tag 5.1 nomenclature and workup strategy.
Yeah, terminology matters here. Small bowel bleeding, SBB, specifically refers to bleeding originating between the ampulla of Vater in the duodenum and the terminal ileum. Obscure GI bleeding, OG, is the term we use when bleeding persists or recurs after a negative initial EGD and colonoscopy and after subsequent dedicated small bowel evaluation, usually meaning a negative capsule endoscopy.
So OG is really when you're scratching your head after the standard workup, and the likely causes depend a lot on the patient's age.
Very much so. In younger patients, say under 40 or 45, you're thinking more about small intestinal tumors like GSs, carcinoids, lymphomas, inflammatory conditions like Crohn's disease, or congenital things like a Meckel's diverticulum.
In an older patient, say over 45 or 50.
The picture flips. Vascular lesions become much more common, particularly angiodysplasia. That's the most frequent cause of small bowel bleeding overall in this age group. NSAID-induced enteropathy or ulcers are also important causes. Tumors are still possible, of course, but angiodysplasia really dominates.
So if the initial EGD and colonoscopy are negative, but the suspicion for ongoing bleeding is high, what's the very first step in the obscure workup?
Often it's actually to repeat the EGD.
Repeat it. Why?
It sounds counterintuitive, but a second look EGD, perhaps done more slowly, maybe with a side viewing scope for the duodenum, can pick up lesions missed the first time in up to 25% of cases. Things like subtle duodenal ulcers, Dieulafoy's lesions, Cameron lesions high in a hernia. It's surprisingly high yield. Repeating the colonoscopy is usually only helpful if the first prep was really poor. Hashtag 5.2 diagnostic modalities for the small bowel.
Okay, assuming the repeat EG is negative, now we really have to look at the small bowel itself. The main tool here is capsule endoscopy, right?
Yes, video capsule endoscopy, VCE, has revolutionized small bowel investigation. It's generally considered the first-line test after negative EGD and colonoscopy. The patient swallows a small camera pill, and it takes thousands of pictures as it travels through the entire small bowel.
Then the diagnostic yield.
It's pretty good, significantly higher than older methods like push enteroscopy. The overall yield is around 50-60% for finding a source of obscure bleeding. The yield is definitely highest if you can give the capsule while the patient is actively bleeding or very soon after an episode.
What are the downsides or limitations of the capsule?
Well, first, it's purely diagnostic. You can see the problem, but you can't do anything about it right then. Second, it can miss things. The overall miss rate is estimated around 10-11%, but it might be higher, maybe closer to 20%, for missing significant lesions like small bowel tumors.
And if there's lots of blood or debris?
Yeah, visualization can be poor if there's active brisk bleeding obscuring the camera view, and rarely the capsule can get stuck if there's an unexpected stricture.
So if the capsule does find something suspicious, what's the next step to actually treat it?
That's where deep enteroscopy comes in. This involves using specialized, longer endoscopes that can be actively advanced deep into the small bowel, either from the mouth, anterograde, or the anus, retrograde, depending on where the capsule suggested the lesion might be.
And these scopes allow therapy.
Yes, that's the key advantage. Deep enteroscopy, whether it's double balloon, single balloon, or it's spiral enteroscopy, allows you to reach the lesion identified by the capsule, or suspected based on symptoms, and perform therapeutic interventions like argon plasma coagulation, APC, for angiodysplasia, clipping, polyp removal, biopsies, etc. It's both diagnostic and therapeutic.
Okay, what if all of this fails? Negative capsule, maybe negative deep enteroscopy, but the patient keeps bleeding. Is there anything else?
For truly refractory, difficult cases of OG where the source remains hidden, there's a niche technique called pharmacologic provocation.
Provoking the bleed. Sounds risky.
It is, and it's reserved for specific situations. The idea is to carefully give medications that interfere with clotting, like IV heparin or maybe antiplatelet agents, under close monitoring to try and induce the hidden lesion to bleed actively.
And then what?
The hope is that once it starts bleeding, you can then immediately localize it with angiography or perhaps repeat capsule or deep enteroscopy while the bleeding is active. It's definitely a last-ditch effort for very challenging cases. Hashtag tag 5.3 small intestinal angiodysplasia.
Let's focus a bit more on the most common culprit for small bowel bleeding, especially in older adults. Angiodysplasia. Remind us what these look like.
They're basically abnormal, dilated, tortuous, thin-walled blood vessels in the submucosa and mucosa of the gut. Little clusters of fragile capillaries and venules. They don't bleed constantly, but when they do, it can be significant, often leading to chronic iron deficiency or recurrent overt bleeding.
Are there specific medical conditions associated with having these or having them bleed more easily?
Yes, they're strongly associated with older age, chronic kidney disease, and certain cardiovascular conditions, most notably aortic stenosis.
Ah, yes. The connection with aortic stenosis is famous Hayes syndrome. Can you explain that link? How does a heart valve problem cause GI bleeding?
It's fascinating physiology. Severe aortic stenosis creates very high shear stress as blood is forced through the narrowed valve. This intense physical stress actually mechanically destroys the largest multisermers of von Willebrand factor, VWF, which is a crucial protein for platelet adhesion and blood clotting.
So it causes an acquired von Willebrand deficiency.
Exactly. You lose the most effective parts of your VWF due to the heart valve problem. This creates a bleeding tendency, and those pre-existing fragile angiodysplasias in the gut are often the first place to bleed because of this acquired clotting defect.
So fixing the aortic stenosis, like with valve replacement, can sometimes cure the recurrent GI bleeding.
Yes, it often does by normalizing the VWF levels. But if valve surgery isn't an option, or for managing the bleeding directly, what are the treatments?
Endoscopically.
Endotherapy during deep enteroscopy is the mainstay if you can reach them. Argon plasma coagulation, APC, is very commonly used to ablate the angiodysplasias. Thermal probe coagulation or clipping can also be used.
What about medical therapies for patients with really frequent refractory bleeding from angiodysplasias?
This is an area with some interesting developments. Somatostatin analogs, like octreotide, usually given as a monthly long-acting injection, have shown some benefit. One trial showed octreotide significantly reduced the number of blood transfusions and endoscopic procedures needed in patients with refractory bleeding from gut angiodysplasias.
And the other drug gaining attention, though it has a complicated history, thalidomide.
Yes, thalidomide. It's known to have anti-angiogenic properties, meaning it inhibits the formation of new blood vessels. Based on this, it was studied for refractory bleeding from angiodysplasias.
And the results?
Quite striking, actually. A randomized controlled trial found that thalidomide led to a significant response defined as at least a 50% reduction in bleeding episodes in up to nearly 70% of patients compared to placebo.
That's a high response rate for such a difficult problem. But thalidomide carries significant risks, doesn't it?
Absolutely. It has well-known serious potential side effects, including teratogenicity, birth defects, neuropathy, and blood clots. Its use requires very careful patient selection, counseling, and rigorous monitoring under strict protocols. But for patients with debilitating transfusion-dependent bleeding from angiodysplasias where other treatments have failed, it represents a potentially powerful pharmacologic option. Hashtag Abschnand outro.
Wow, we have covered a massive amount of ground today, from those first critical moments of resuscitation in the ICU all the way to the meticulous, often frustrating hunt for tiny bleeding vessels deep in the small bowel.
It really spans the spectrum of gastroenterology emergencies. To quickly summarize some key takeaways, we hammered home the superiority of the restrictive transfusion strategy, aiming for that hemoglobin target of 7 to 9 for most patients with GI bleeding.
Right, and the absolute necessity of giving antibiotics to all cirrhotic patients admitted with upper GI bleeding, regardless of the cause, to improve survival.
We also made sure to differentiate GAVE-E, the watermelon stomach, which is not related to portal hypertension, from portal hypertensive gastropathy, PHG, where pressure-reducing therapies like beta blockers or TIPS are effective.
And finally, we outlined that systematic, stepwise approach needed for obscure or small bowel bleeding. Repeat the EGD first, then move to capsule endoscopy, and follow up with deep enteroscopy for diagnosis and therapy if a lesion is found.
And connecting back to those high-stakes decisions, think about those two major shifts we discussed. First, the incredible impact of preemptive TIPS, PT2, how it's dramatically changing survival for those highest-risk variceal bleeders by intervening early and definitively.
Yeah, shifting it from salvage to upfront therapy.
Exactly. And second, the emergence of potent medical therapies like thalidomide showing real efficacy for controlling refractory vascular bleeding like angiodysplasia, something previously managed almost exclusively endoscopically or with supportive care.
So that really brings us to a final provocative thought for you, our listeners, to consider. If we continue down this path, developing more effective pharmacologic agents that target the bleeding lesions themselves, and refining preemptive interventions like TIPS for high-risk groups, how might these non-endoscopic approaches fundamentally change, maybe even reduce, the traditional role of the therapeutic endoscopist in managing acute GI bleeding over the next decade?
Will endoscopy become more diagnostic and less about primary therapy in some of these conditions? It's definitely something to think about as the field evolves.